Good afternoon, everybody. I want to thank Brian Starmet and Dr. Douek for putting this excellent conference on. It's really an honor to speak with all these experts in this field. And I'm going to talk about what sounds like a bit of a niche area, pacemaker and implant compatibility. But if you do this long enough, you will come across this problem. Some disclosures. Here are my disclosures. My biggest disclosure is that I'm going to talk about cardiac electrophysiology, which I clearly have no business to talk about, and that Dr. Douek talked about this. The bipolar electrode may make everything that I'm going to talk about moot. So hopefully so. But that said, let me start with the case. So there's a 71-year-old woman who has this enlarged goiter causing cough, shortness of breath, discomfort with swallowing, so typical symptoms. And this large nodule, it's biopsy proven benign, it's about 52 cc's. And she has this chest x-ray, which shows that her trachea is narrow, leftward deviated, but she also has this, this device here. So this is the first case I did in a patient that had this cardiac device. And this is a dual chamber pacer device, and we'll come back to this case afterwards. But let me show you this case, case 2, 85-year-old man, very similar story, has a 38 cc right lobe nodule, biopsy proven benign, having severe symptoms, really positional symptoms. And this is his chest x-ray, so another device here, and this one has this thick lead, which is a shock coil, so this is an ICD device. And so we'll talk about sort of what these things mean and some of the protocols that we've developed in my practice to deal with some of these considerations. So first, I'm going to talk about a little about current practice and what's out there. We'll talk about CIEDs, what they are, and EMI, monopolar versus bipolar. Some of the proposed algorithms that really exist outside of the context of thyroid RFA, but which we've applied to thyroid RFA, and then finally our approach to these patients. So current practice, if you Google thyroid RFA and pacer, you'll come to this page from UCLA, which is where I'm from. And you'll notice that it says patients with cardiac pacemakers should not undergo RFA. And I wrote this a few years ago. And if you look online at many academic institutions or places that do these procedures, thyroid RFA, you'll see the same thing. Patients with cardiac pacemakers or other implanted electronic devices cannot undergo RFA treatments, and so on and so forth. Patients who are pregnant or have pacemakers should not undergo these treatments. And so this sounds like, if you do a Google search, that this is an absolute communication. But I'm here to tell you that that's not true, that patients with cardiac implantable electrical devices, CIEDs, can in fact, even monopolar, with monopolar electrodes, can in fact undergo RFA. It's not easy, it takes a little bit of legwork, but I'll go over some of the protocols that we've developed. How about the guidelines? So this is the Korean guidelines 2017, and they say maybe a little bit more elegantly than the way I said it and some of the Google search says it, but although there's no absolute contraindication for thyroid RFA, we do not recommend the use of monopolar electrodes for patients with electrical devices such as cardiac pacemakers, and bipolar electrodes can be a safer selection for those patients. Very true, we'll talk about that a little bit. The problem, however, is right now bipolar electrodes in the United States at least are very hard to come by. So first, a little background on these CIEDs, or cardiac implantable electrical devices. These are very common. So 3 million people in the US have conventional pacemakers. Another 800,000 have ICDs that will shock the patient if there's a tachyarrhythmia. And 400,000 in the US alone are implanted. So if you do this, or anything in medicine, you will encounter a patient with one of these devices eventually. Simplified version, there's sort of 3 buckets of these CIEDs. So one is permanent pacemakers. Those are for patients that have bradycardia. The device will monitor the heart rate, it'll give electrical impulses, trigger the heart rate when necessary. There's ICDs, which can deliver life-saving shocks when there's a tachyarrhythmia that's detected, and those can often be combined with a permanent pacemaker. And then cardiac resynchronization therapy devices, CRTs. These are used in patients with heart failure, really to help coordinate the ventricles for more effective. effective pumping. This is not entirely comprehensive, but those are the three major buckets. So EMI, so what is EMI? What is electromagnetic interference? So during RFA, we're delivering an alternating electrical impulse. And what that's doing is that's flowing from the RFA electrode through the patient to the dispersive ground paths in monopolar context. So here's a little depiction from the neck through the torso and down to the ground paths that are either at the torso or in this case at the thighs. And those electric fields that we employ during RFA, those can cause electrical interference, which is sensed by the CIEDs. And so that introduces basically 3 risks. Again, this is simplified. One, the pulse generator may sense that the heart is beating faster than it in fact really is because of that EMI. And this might lead to underpacing, and the patient therefore might really be profoundly bradycardic without that pacemaker responding, or even asystolic in a patient who is pacer dependent. 2, that EMI may be misinterpreted as a tachyarrhythmia and might shock the patient during your procedure, not an elegant way to go about things. Or 3, there might be direct damage to the CIED, which I'm told with newer devices is very uncommon. Or you might reset the programming of the CIED, which is more common. So those are the risks in a nutshell. What about this concept of monopolar versus bipolar RFA? And Dr. Douek showed some of this, but in the monopolar context, as we said, that current is traveling through the body to those grounding paths, which are typically at the thigh. And so that electric current is traveling through the body and perhaps affecting the CIED. The bipolar, and this is the start of my bipolar device, not currently available in the US, but hopefully is soon. That current is localized. It's localized to the electrode tip. The energy starts out at the tip, and then the grounding is actually within the tip there. And so there are no grounding pads, so it's a very localized current. The ablation zone, Dr. Douek told us, similarly sized, but more ellipsoid in contour. I've never done this, so I haven't seen this. But the main problem right now is that these are of limited availability in the United States. So for the time being, in some ways, we're stuck with the monopolar context. So we developed sort of our algorithm and our protocols by taking from other medical contexts, because this is not a problem that's unique to thyroid RFA. These pacers and CIEDs are ubiquitous, and we've been doing radiofrequency throughout the body for many decades in liver and lung, kidneys, bone. Pain services are doing this for pain control. Cardiologists are doing this for cardiology. So this is not a unique problem, and there's a number of guidelines that have been developed, namely in the anesthesiology literature, that I've sort of picked and chosen some of the guidelines from. You also see this in electrosurgery, the Bovie device, other things, radiofrequency identification devices, lithotripsy. Something I'm very familiar with as a radiologist, MRI, and anybody that has an MRI service, we're used to seeing patients with pacers, and we have a pacer team that helps to manage these patients because MRI reduces EMI as well, and so forth. So not a unique problem with thyroid RFA, but there's not a ton of literature on thyroid RFA and managing the devices specifically. So this is what sort of I've garnered from that literature. And the first question occurs really, of course, in the clinic, in a clinic evaluation, and it's, does the patient in fact have a CIED? And at that time, why? Why is it? Is this an ICD? Is the patient pacer dependent? And those are some of the questions that you will not be able to answer. But communication with the cardiology office at that time of the first visit is critically important. So if I have a patient with a CIED, after the visit, the first thing I'm doing is phoning the cardiologist's office and involving them in this conversation. And sometimes they'll even give you a device management prescription. We also, again, have a electrophysiology team that will be present during our procedure, and they're used to doing this, and I'm used to them. They do this all over the hospital, but they do it for us in the context of MRI. So I know some of them, and I'm familiar with them, and they've been excellent and really helped us out. The device is typically interrogated at a regular basis, and the cardiologist should be able to provide that device interrogation, and this is, ideally within 3 months for an ICD or 6 months for a permanent pacemaker device. So this is sort of the preoperative workup that you have to do. It requires coordination with cardiology and the electrophysiology teams, which are often under the auspices of the cardiologist. At the time of the procedure, every case we've done thus far, and this is not a huge volume, but a handful of cases, the PACER team is available during the procedure, and they're going to ask 2 fundamental questions, and that comes from the PACER interrogation. Is the patient pacemaker dependent, or is this sort of just a backup? And if the patient is pacer dependent, they will reprogram that to an asynchronous pacing. So irrespective of what the pacer senses, the pulse generator will have the patient, will deliver an electrical impulse, have the patient paced at 80 to 90 beats per minute, and forget about what the pacer sees. And the second question is there an ICD present? If there is, they'll typically suspend the shock algorithms. And they can do that by programming it or via backbending. They're very used to doing these things. And then all of these, one of the nice things about RFA is this is an outpatient procedure, minimal sedation. This is not the guy that you want to take to some clinic where there's no support. So we're doing all of these when we do these in a hospital environment where you have the availability for temporary pacing and defibrillation and to continuously monitor these patients that's supported, and the pacer team that's there present during the procedure. And finally, some intra-procedural considerations, some ways to mitigate EMI. One thing that's advocated is the RF circuit should be as far away from the pulse generator as possible. So if you have a left chest wall pacer, if you put the grounding pads on the contralateral thigh, that circuit theoretically will travel away from the pacer device and you'll have less risk of erroneous sensing. And using brief and intermittent ablation, turning the energy down in this case rather than up to the lowest possible energy to get an effective ablation. Finally, after the procedure, there's not much to do. If the patient was reprogrammed during the procedure, then obviously having the patient team put it back to the original settings. And we fortunately, knock on wood, have not had any issues, but if there's any abnormal cardiac rhythms or any device-related complications, low threshold to get cardiology involved. So again, most of what I've talked about is taken from other contexts, but there is this one article that from Bernardi from 2016 that talks about the management of these CIEDs, specifically in thyroid ablation cases. And really, again, the questions are, is the patient pacer dependent or not? And does the patient have an ICD or not? And a patient without an ICD that's not pacemaker dependent, there's really not much to do except monitor those patients. Those patients are considered lower risk, and the higher risk patients would be those that have an ICD that might get an erroneous shock. And our pacemaker dependent they'll be underpaced. So those are the ones that we're a little bit more about and make sure we get, in every case we're getting cardiology and pacer team involved, and in those cases especially. Just to summarize our approach, we talked about all these things, but first thing we do when we find a patient with a CID is we consult the cardiology team or CID care team. We make sure that there's been an interrogation report of that CID. Is the patient have an ICD? Is the patient pacer dependent? What's going on? And we contact our pacer team and make sure that when we schedule the procedure, they will be available with us in the room. They will ask if the patient has an ICD. They will suspend the tachyarrhythmia treatment algorithms. If the patient doesn't have an ICD, just a pacer. Is the patient pacer dependent? If they are, they'll change it to an asynchronous mode. If they're not, simply intraprocedural monitoring. Anything they change at the end of the case, they'll change back. Every case is done in a monitored environment with the availability of a higher level of care if need be. And some ways you can mitigate problems is putting grounding pads on the contralateral thigh as the device and using lower energy than you otherwise would. Okay, so coming back to our cases. So case one, with this device, this CID interrogation, this is a dual chamber Medtronic pacer. This is what some of the things will look like. There is no ICD. The patient is not, but very near pacemaker dependent due to junctional blocking authorities. And the pacer team will write an impression. They'll be there for the procedure and they'll write an impression. In this case, the patient was monitored only, no adverse effects. The patient did very well. We put at their suggestion, we put the grounding pads on the contralateral thigh, and no programming changes were made, and there was no issues throughout the case. This was the first case we did, and since then we've done a number of cases. This patient had the ICD, and the interrogation, this is Boston Scientific, biventricular PPM ICD. The patient was not pacemaker dependent. They suspended the tachyarrhythmia algorithms for the entirety of the case, monitored the patient throughout, any problems. The patient did very well. Both these patients did very well, as have the others that we've done in this setting. So to summarize, presence of CIEDs certainly presents some challenges, some logistical challenges, but patients can still undergo thyroid RFA safely, even if they have a monopolar RFA, which is the majority of what we're doing these days. If you take the time to establish these appropriate protocols, it should only be performed in a setting allowing for patient monitoring and urgent intervention. This, of course, requires, as everything we do, a multidisciplinary approach with the involvement of cardiology and electrophysiology or PACER teams. And bipolar electrodes may make this entire conversation moot for significant safety advantages because of a dramatic reduction in the EMI. So thank you. Any questions?
No.
Are there other devices that we should be concerned about when it comes to interference?
Any other devices?
Other than cardiac, like spinal stimulator?
Yeah, spinal stimulators, sort of similar considerations, and there is same sort of team that can put those on surgery mode. We do that also with MRI. They put it on sort of safety mode or MRI mode or surgery mode, and same idea is you reduce EMI feedback in any decisions that are made based on
any metal in the body, like somebody has like artificial hip or something, metal.
We've done it patients with artificial hips with no problem. I don't know if anybody else has comments on that, but any metal in the body is you're supposed to be wary of, but I've never had an issue with that.
Both grounding pads contralaterally?
Both contralateral, yeah, we do front to back. Yeah, we often do torso, but in this case, front to back thigh is how we did the case.
Quick question about the bipolar probe. So when they become available for space, is there any need to involve the cardiology team when using them at all? Is there any?
I don't know. It's a good question. I don't think so. I have to drag the PACER team a little bit. They're very nice people, but these are cardiologists, and they do RFA in the heart, and they're like, "What are you talking about? What's the problem here?" I'm like, "Just please come." And so my guess is that I would have them present for the first cases to make sure, but that very quickly, if we don't see any interference, they probably would not be necessary. Yeah.
Any comments about fillers or like breast augmentation? Anything specific for these cases?
I've never had an issue. It's never been a problem, and I have had patients with breast augmentation.
So no cautions for these cases? Thanks.
Thank you.
Thank you, Dr. Douek.